My name is Charlotte Humbles, and I have a order for a NG2 insertion and an intermittent suctioning. Before I do anything, I will follow a principle-based checklist, including safety, privacy, standard precautions, body mechanics, hand hygiene, two identifiers, and documentation. Okay. I would explain what I'm doing, check the orders before I do anything, to confirm. I would check the nearest patency, choose the right side. If patient is combative, I would do this in low fowlers, and I would have another coworker assist me also. Well, if they're comatose. If they're combative, then I would just have another person assist me. I'm going to raise their head to high fowler's position. As for the tubing, if this is a plastic tube, I would just use warm water, water basin. If this was a rubber tube, I would set this on ice for 10 minutes. For small bore tubes, it will come with a stylet or a guide wire. The guide wire has to be in place until insertion is confirmed, and it stays in place until insertion is confirmed. And once you take the guide wire out, you cannot reinsert it. At this point, I'm a measure. I'm gonna mark with tape.
I was like trying not to look at the drawers because it's like I'm spacing. Yeah. Right. Do you want it sideways or probably sideways? Yeah, give me the worst angle. Hold on.
I'm going to ask the patient if they could swallow. I'm a drink a linen saber pad. If the patient can swallow, I am going to hand them a glass of water with a straw. Also going to hand them an emesis basin for tissues. Where's the tissues? Oh, there's
What did you take? I didn't even notice. Oh well, we can't help that.
Then I am going to measure. Oh, well, I already measured and put it. After measuring, I'm going to do hand hygiene and don gloves.
What? Alright, I think this one's yours. We're both. Alright, Lex, let me just remember to do like this will remind me of other stuff.
Now, instead of putting this in a warm basin, I'm going to wrap this around my fingers a couple times to loosen it up. My index finger.
That's just too much for me. Let me know when you're ready and I'll give you a signal. So nervous. Okay. Hi, I'm Molly.
Alright. I am right-handed, so I'm standing on the right side. If I was left-handed, I'm standing on the left side.
Oh, yeah.
I would begin with the insertion.
So we've done that. We're going to do an open tube system. So we'll be using a syringe. So I've gathered my materials. I have a syringe right here.
I will prepare my fixation device before I start and a temporary piece of tape. I am going to lubricate the end without actually dipping it on there. I'm going to put it in the package. I guess I can start inserting now. Oh, before I start, I'm going to ask the patient to hyperextend their head. Could you push your head back against the pillow, please?
30-degree angle to prevent aspiration.
Just past the nasopharynx, I'm going to start rotating this towards the opposite mirror.
Prior to inserting, I enjoy
that, I am going to tell the patient the next steps requires him to swallow, and also to flex his chin into his chest. The swallow ratio is going to be 2 to 4 inches per sip.
So, first, check the placement, verify the placement of the tubing in the patient's stomach, and we'll do that with an X-ray, but also
I'm going to use my temporary piece of tape. And this is just temporary until the nurse checks placement. I can also check placement by measuring the stomach contents pH. I can do X-ray. I can ask the patient to speak. I can also inject air and osculate. And I can measure. I'm going to measure the tubing. So if tube is not in stomach, I'm going to advance 1 to 2 more inches, and then I'm going to follow those steps again to check placement. Now, if this were a small intestine insertion, I would have patient lay on their right side and advance 3 to 4 inches hourly up to 24 hours until checked by X-ray. If this was a nasal enteric insertion, I would have to advance 3 to 4 more inches. So then I will do my fixation device after everything is checked.
So, once we're done with that, I will take off the drape. Just make sure nothing's spilling around here. And that is about it. Thank you. I will
I would
take off my gloves and my facial hygiene, and I will absolutely dump
take the patient's cheek if possible. I don't know if this is possible. I would prepare a slip knot.
That's okay.
Put that on there.
Did I get the stuff that's needed?
Yeah, you did.
That's all I remember that was needed. That was fine too.
Yeah.
I prepared my fixation device, like, and I will leave it here.
I never introduced myself.
With a safety pin, I would put it on the gown. If I do not have a safety pin, I can also use tape.
I have too much going on in my head.
I like to push them.
And I'm going to
I would gather my supplies. Oh, one more step. If patient starts gagging, I would stop, tell them to take a couple deep breaths and a few sips of water. If patient continues to gag, I would check to see if it is coiled in the back of the throat. If tube is coiled, patient won't stop gagging, respiratory distress, what else? Excessive coughing while insertion. Then I would stop, take the tubing out, allow the patient to rest, and then I would come back and reinsert it. I am forgetting something.
All of them? Okay. Okay.
For subsequent feeding, I would have to measure the pH with a pH strip.
So I just
I think.
or the because you need
And then I would let the roll up, put the bed down, document everything, safety check, the rest of aided, wash my hands, remove gloves, and document. That's it. I would make sure the head of the bed is at 30 to 45 degrees after inserting it. I will also mark the insertion with an edible ink or tape, and I would measure the tubing, and I will record those things in the chart, and then I would document.